This morning, we're really, really excited to have Dr. Jo Lawrence join us this morning. So Jo is Paediatric Lead of the Victorian Virtual ED and Medical Lead for the Virtual Health Team, Consultant Paediatrician for Hospital in the Home, and also the Complex Asthma Service at RCH. She's got a suite of titles behind her, which she will further discuss, but it's all coming around to a very great presentation, which is delivering on virtual care models for paediatric populations. Jo, I'm really excited to hear this morning what you get to talk about, and I'd love to hand over to you.
Oh, but before you do,
sorry.
I just also want to make sure everyone knows that she was a fellow in the Academy last year and was a great example of where her project was really aligned with her job. And so she was able to make huge progress. So.
How could I forget that? All right, Jo, over to you.
All right, I'm going to try and share my screen. I may have to share first. Share screen 2. Share. And then from beginning. All right. So thank you, Meg. Thank you, Wendy. It's an honour to be here today and share my journey with digital health. Before I begin, I'd like to acknowledge the traditional owners of the land on which we're meeting and pay my respects to elders past, present and emerging, and recognise that we're all meeting from different traditional lands today. I'd also like to acknowledge that the work I'm presenting today is a broad body of work, and it has obviously had many, many people contribute. So a special acknowledgement to the virtual care team at RCH, Diana, Andrew, Jen and Phil, and also Lauren Scher, the Director of VVED, and Deputy Directors Susie and Jason, as well as all the clinicians, admin staff who contribute to the service every day, and to those that were involved in the co-design. So before I get really started, I wanted to share my journey with digital health. This is me fresh out of medical school. And if you had asked me then where I was going to land in my career, I would have found it very difficult to picture where I am now. And this is a photo from the Digital Health Fellowship last year. What I anticipated to happen was my career would continue in a straight line trajectory, which had been the course to date. I'd come straight out of high school into medical school. I'd got my letters in paediatrics and collected a master's on the way, and I expected to continue a straight line trajectory straight into an inpatient general paediatric job. But of course, life never delivers the way we anticipated, and life got a little bit more bumpy. I had a number of setbacks in my career. I had a few babies, collected more and more qualifications, so clinical teaching, health economics, medical administration, and I finally ended up with a role as a hospital in the home consultant. This role I applied for because it really appealed to me and aligned with my values in sustainable healthcare and thinking about the way we deliver healthcare differently. At the same time, I went for a role with the EMR team, and this is not at all because I'm a technologically savvy person, quite the opposite. I still hand my phone to my husband to troubleshoot. But really, I had returned from maternity leave and found that the EMR had completely transformed the way we were providing clinical care. And I wanted selfishly to improve my own interactions with the EMR and become a little bit more proficient. And I also had been through the onboarding, and it was very tech heavy, and I thought I could use some of my clinical education expertise to make it based around adult learning principles and more problem-based learning. I never anticipated I would continue with the EMR team, and yet I'm still with them today. And a big reason for that was my mentor, one of my mentors in that team, Lauren Andrew, who was a fantastic leader and also got a small grant from Safety Care Victoria to look at choosing wisely. So reducing tests, treatments and procedures that have a little benefit and can cause harm. And she asked me to be the medical lead. Obviously, that project fully aligned with my interest in sustainable healthcare and reducing waste. And that led to me taking part in the Digital Health Fellowship last year, which was a good intersection looking at how we can use the EMR to improve the value of care we provide. When the Royal Children's Hospital decided to invest in virtual care, with my interest in alternative care models and my growing interest and appetite for technology, it was a natural fit for me, and I became the Royal Children's Hospital Virtual Care Lead. As part of this, we proposed a virtual emergency department to our emergency department staff, and there was great hesitation. There was concerns that this might not divert from physical ED and could just create scope creep. So instead, we got funding from the Northwest PHN to design the ultimate virtual urgent care service for paediatrics, and I led that co-design process. During that time, the Victorian Virtual ED got funding to go statewide, and rather than create duplication and inefficiency in the system and create confusion for consumers, we elected to use our co-design sessions to inform the Victorian model. I was asked to be the chair of the Paediatric Advisory Committee and then ultimately to join the VVED as the Paediatric Lead. And that's where I'm at today. So I hold 4 very varied and interesting roles, all of which align with my values and interest in contributing to a better healthcare system, and none of which are on that original trajectory. But I'm very, very grateful for where I've ended up. So what I'm sharing today, I wanted to share some of the thinking around the virtual care models that we've stood up at the Royal Children's Hospital. Predominantly, we've been using the EMR portal, and then the VVE co-design process and where we've landed at currently with the VVED. I'm hoping that through these experiences, I can share with you why we absolutely have to have virtual care as part of our future, and we can't continue to rely on traditional models of care. That technology is an important enabler, but it's not about the technology, it's about the model of care. And in order to inform the model of care, we really need to understand what the problem is that we're addressing and start with the problem, not with the shiny new tech. We need significant input from our consumers and clinicians. And once we have that input, we can really understand where the value add is, which supports the implementation. Given we're at the beginning of this journey, evaluation is absolutely critical to inform which models add and which models are simply contributing noise and extra cost to our healthcare system. Hopefully, I don't need to talk too long to this slide. We know we need virtual care. We've got a healthcare system which is experiencing increasing costs. We spend more and more GDP every year on healthcare, and the costs are rising unsustainably. Every healthcare system is under significant financial pressure post-COVID. We've also got a workforce that is burnt out. We've all come through COVID. We all worked extra hard in COVID, and now we're feeling tired. We've got a growing population of children. A lot of those children have increasing complexity with their healthcare needs, given our ability to support children living longer with more complex illnesses. So we're being asked to do more with less. We've also changed the way we interact with the world over time. So we no longer, if we think about banking, I can't remember the last time I went into a physical bank. I can't even remember the last time I used my card in an ATM. I simply wave my phone everywhere and get what I want these days. I'm giving my children very mixed messages about what money is. But consumers are expecting to engage with the world differently. If you look on a tram, everyone's on their mobile device. It's time that healthcare starts to move with these changes and start to interact in a different way with consumers. And we know that we can. During virtual care, there was a significant shift towards virtual care models. What exactly is virtual care? Some people think about telehealth. You might think about asynchronous messaging, healthcare apps that help drive healthy behaviours, portals where you have access to your own healthcare information, your own test results, and can communicate with clinicians, and remote monitoring. But in fact, none of these are virtual care. These are the tools and the enablers, but virtual care is the bit in the middle that takes those tools and enablers, wraps the clinical model around them, and delivers the meaningful outputs. This is what we've visualised at the Royal Children's Hospital, that we need to start with the clinician and consumer pain points, and then bring in the governance, the consumer collaboration, the clinical and technical expertise to come up with co-design solutions that really meet the needs of our consumers and clinicians. To highlight what I mean by a model of care, I wanted to share with you the story of Zach. So this is 10-year-old Zach, and he's sitting here with his mum and brother. He's got cystic fibrosis. He was last seen in clinic a month ago, and at the time it was school holidays, and his older brother, who was concentrating on his exams, had to come along. His younger brother, who gets a bit bored, had to come along, and his mum had brought iPads so that they could be busy, one studying, one playing, so she could really focus on the consultation. She was given some written information at the end of that consultation, and she folded that, popped it in her bag with the boys' iPads, and They hurried off home where she had to cook dinner. When Zach develops a wet cough, she remembers that she's got a treatment plan and thinks that she's supposed to start antibiotics, but she can't for the life of her find where she put that piece of paper. She knows that the cystic fibrosis team are really busy and would prefer not to bother them. Zach has a clinic appointment in 3 weeks and she elects just to wait for that appointment. By the time Zach is seen in clinic, he has spirometry performed, which shows that he's got a significant deterioration in his lung function. He therefore has to be admitted to hospital for IV antibiotics. Now, this is a really bad outcome for Zach because he hates being in hospital, he hates being away from his pet dog, and he's got needle phobia and absolutely hates having IV antibiotics. Imagine now if Zach and his mother could participate in a symptom tracker. That would detect when Zach's symptoms changed and he's got an exacerbation. His mother gets pushed his personalised treatment plan, reminding her what antibiotic to start and that he should go up to twice daily physiotherapy. He starts that. He continues his symptom tracker, which detects that he's actually not improving. That then prompts a telehealth review with his treatment team and a home spirometry, which leads to his change in his antibiotics to a different oral antibiotic. By the time he's seen in clinic and has spirometry, his symptoms have resolved, his lung function is back to normal, and he's avoided that admission to hospital. What a better outcome for Zach. And so when we talk about virtual care, we're talking about the model of care, and it certainly uses innovation, it uses technology, it leans heavily on our consumers to inform the design. And what we're electing to do is provide both consumers and providers the choice to provide care differently. We want to overcome some of those geographical barriers so that you can receive care regardless of where you live across Victoria. Virtual care allows us to scale care, so it's contributing to a sustainable healthcare system. It's a more equitable healthcare system, and it's really focused more on our consumer and how we fit into their life rather than archaic traditional models where consumers travel to the hospital and get their care. The Victorian Virtual Care Strategy has recently been released, and this has 2 key points that align with our strategy. One is that we should be offering virtual care as a choice, and 2, that we should be embedding this in everything we do. And that's available if anyone wants to read that in more detail. There are different frameworks for thinking about virtual care, and this is one that I like. It starts with substitution, and I would argue that none of our virtual care models are substitution. That's simply digitizing an existing workflow. What we look to do is augment, so to provide additional value in any model of care that we put forward. And ultimately, we're looking to modify or redefine healthcare so that we're really providing a transformative healthcare landscape. I'm now going to share with you some of the models of care that we've rolled out at the Royal Children's Hospital. First, looking at how we've augmented care. So we've used these models of care to create efficiencies and to try and shift some of the administrative burden away from the clinical staff so that they can be freed up to concentrate on higher value clinical tasks. The first I'll share with you is the preoperative screening questionnaire. So initially, every patient before they come into operation needs to have a screening questionnaire completed, and this was being performed on the phone. It was taking a huge amount of EFT, and it seems quite a simple solution just to pop that onto the portal and get people to fill it out in digital format. But of course, nothing is as simple in real life, and this was actually a very complex process. There were many different stakeholders involved. The anaesthetist wanted something out of it. The surgeons wanted something out of it. The nurses needed to fill in their preoperative or their pre-admission forms. There were questions on there that were very unclear what the purpose of asking that question was. So we went through every question to understand what was the purpose of that question, which clinician needed to see it, and what was the action that needed to come out of that, which of those responses needed to be escalated for earlier attention. We wanted to make sure that every single question asked of our consumers was meaningful and actionable. We also wanted to make sure we were putting forward an equitable model. So we needed to continue with the phone model for those that were not health literate or digital literate and couldn't interact with the portal. We needed to understand the clinician's workflow, to understand where those results would need to flow into, to make sure that they were visible to the clinician within their daily work so that they could be actioned and seen. And we wanted to start small, test it, and then roll out and scale. In the initial rollout, we tested it on an ENT cohort over a period of 2 weeks. These patients were sent a text to sign up for the portal, and you can see that 80% of patients were successful in signing up to the portal. We then did a time and motion study and discovered that the call without the portal took approximately 10 minutes, and with the portal, it was 4.65, so less than half the time if the patients had filled out the portal questionnaire first. That was a saving of over 3.5 hours just in that 2-week period on a very small cohort. We then scaled it up to other cohorts over a longer period of time. You can see that blue is with the portal, and you've got a much higher percentage of calls of shorter duration. And the calls lasting more than 15 minutes were much more likely to occur if you hadn't done the portal questionnaire. There was not only a saving in nursing time efficiency that they could repurpose to higher value tasks, but the clinicians said that those phone calls were more meaningful as well. So they were able to better prepare for the phone calls and use that time on the phone to talk about the problems or the issues that were really meaningful and pertinent to that family. It frees up time for us to speak to anxious parents so they were able to allay a lot of concerns before the patient came in for surgery. And the parents were really grateful. So they felt they were getting much more information and help from that phone call than simply information gathering. Another example of augmentation is our hematology model. So in the past, patients monitoring their warfarin at home would collect their INR on a device. They would ring up and leave a message on the answering machine. The clinical nurse consultants would then listen to the answering machine at the end of the day. They would transcribe the results they were hearing into the EMR and then return any phone calls where warfarin needed to be altered. You can imagine the amount of time that was taking and also the risk of transcription errors. We therefore designed a model of care where the patients would put their INR directly into the portal, and that would flow directly into the EMR, so there was no longer a risk of transcription error. The results were visible to the clinical nurse consultants, so at a glance, they could tell which patients they needed to contact, and they could either do that via phone or via the portal messaging, and which patients were fine. And in a pilot of 36 patients, there were 405 completed questionnaires, so that's 405 phone calls that they've avoided. 146 of these were prioritised for clinical intervention, and the rest were able just to continue. And 135 hours of administrative time was saved for our clinical nurse consultants who are highly skilled and could then use their time and expertise in clinical tasks rather than an admin-heavy task. If we consider modification, so this is even further where we're thinking about how we provide care differently. We're adding value, improving the quality of care, providing care between the gaps, and really enabling ourselves to scale and improve accessibility. This is the patient population attending the complex asthma service. To be qualified for the complex asthma service, you need to have some complexity to your asthma, as the name would suggest. So either frequent presentations to hospital or really severe presentations ending you in ICU, or some social or comorbidity that renders your asthma more difficult to manage. These patients get contacted by our nurses every month, and they need constant tweaks to their management. When the patient load was 50 patients, this was really a feasible task for our 2 clinical nurse consultants who share the job between them to contact these patients every month. But by the time the patient load got to 100 patients with no increase in staff, it was really becoming an overwhelming task. And they were concerned that there were patients that they weren't able to contact, they didn't know how they were traveling, and they wouldn't see them again until they turned up to clinic, or worse, were admitted to hospital. And so we designed a portal model to collect the information every month. We used a validated questionnaire, and the nurses could easily see which patients were stable and which patients were deteriorated and needed their time and attention. From the consumer perspective, they were really grateful for this model of care. They reported that it's not always convenient to take a phone call. They might be in the supermarket, it's not a private environment, they might not be in the headspace to think about their child's asthma. Whereas if they can answer that portal questionnaire in the evening, with a cup of tea, the kids are in bed, they're able to give much higher quality input. This is the model of care I shared before with Zach. So patients with cystic fibrosis, traditionally, are seen in hospital 5 times a year and 5 clinic visits. And in between times, it's really up to the parents to reach out and contact the hospital should there be a change in their patient's condition. We know that that leads to under-recognition of symptoms and therefore under-treatment of exacerbations. And if you have repeated untreated exacerbations, or the exacerbation gets to a point where it's much more severe, this has an impact on your lung function and ultimately your rates of your life expectancy. So by putting in place the symptom tracker, we did a proof of concept over a 6-week period with 5 patients, and we detected 3 exacerbations that otherwise would have gone undetected and untreated. Jen Corder now is running a randomized pilot RCT to look at the outcomes. And what we're hoping to show is that this model of care will reduce an earlier detection, more aggressive treatment of exacerbations, which ultimately will lead to less hospital admissions, less impact on lung function, and improved mortality. So that's a really exciting project that we've been involved in. Finally, redesign. How do we rethink how we deliver care? During COVID, we redesigned hospital in the home. So traditionally, hospital in the home nurses deliver care outside hospital walls, but they drive to the patient's home, provide a care intervention, and drive back. During COVID, we were admitting patients with COVID to hospital in the home, and we were continuing with our in-person model. The nurses were driving out to the patient's home. They were donning and doffing PPE on the doorstep, which was quite stressful. And then they were driving off to the next patient. And that next patient might have an oncology issue. So they felt really unsafe. They felt they were at risk of transmitting disease, not only to themselves and to their families, but also to the next patient they were visiting that was quite vulnerable. We also saw an exponential rise in cases, and we weren't sure how high this would go and how we were going to manage. So we needed a scalable model of care. We designed a completely virtual model of care. Patients were reviewed by telehealth, and they had the remote monitoring equipment in the home to enable us to get a holistic picture of that family. In between telehealth reviews, they were filling in a 2 to 3 times daily questionnaire that checked in on their symptoms and asked them to input their SATs and their heart rate. Our clinicians were operating from a dashboard where they could easily see who was stable, who was deteriorating, who should they contact next. So it allowed them to prioritise and give their clinical time and attention to the patients who needed it most. Not part of the intentional design, but one of the most popular parts of the model was the ability to communicate asynchronously. This was at a time where patients and families with COVID were receiving multiple phone calls from the Department of Health, from adult health services. There was a lot of phone tag going on. So the ability to send a non-urgent query via text and have a response via text was seen as a real benefit of this model of care. And over the 6-month period, we had 162 patient-initiated symptoms recorded. So that's 162 phone calls we avoided, or telehealth visits we avoided, because we could collect that information. And then when we jumped on telehealth, we were able to go straight to the symptoms of concern rather than simply collecting information. We had much improved efficiency. We were able to increase our nursing ratios from 1 to 5 to 1 to 15. And our staff were relieved. They were no longer having to don and doff PPE on the doorstep. They were no longer having to travel between patients with an infective illness to patients with an oncology illness. And there was far less wastage, and our patients were happy as well. And that led to a whole redesign of our service. So instead of driving to 5 different patients' houses in a very scheduled and rigid schedule, we were able to be more proactive, more responsive, have oversight of a greater volume of patients at the same time, and really spend our clinical time and attention to those that needed it when they needed it. The other area we've started to do is look across the entire patient journey. So all the examples I've shared with you to date are isolated areas where we've noticed there's ways we can be doing things differently. But we're now starting to look across an entire patient journey. If we consider the ENT patient, they get referred for clinic, they then get seen by the ENT surgeon who waitlists them for surgery, they then have their operation, are discharged home, and they have a journey to recovery. I've already shared with you the pre-surgical questionnaire project. We're also looking at an ENT questionnaire project when they're on the wait list, which will allow us to reprioritise. We know the waiting list for surgery is up to 2 years, and this has been exacerbated by COVID when we weren't able to operate. So now, by completing a portal questionnaire with a validated symptom questionnaire, we're able to see which patients have natural resolution of their symptoms and no longer need surgery, so we can take them off the wait list. And conversely, which patients are deteriorating, so they don't sit on the waiting list quietly deteriorating, they get reprioritized and bumped up the surgical wait list. So we can offer surgery to the patients who need it the most, the right patient at the right time. Similarly, there's been a model of care which Kate Simpson led, which was transitioning ENT patients to hospital in the home rather than in the hospital. But in addition to that, Beck and Claire, our ENT clinical nurse consultants, have been driving a model of care whereby patients fill in a portal symptom questionnaire on day 1, 3, 5, 7, and 9. And if there are any changes in that, if we notice that the patient has poor pain management, if they're not eating and drinking as well as they should, if there's any bleeding, they're able to get a proactive phone call and manage those symptoms at home before they get to the point of uncontrolled pain and dehydration and need readmission to hospital. And we've avoided at least 6 representation using this model of care. There are obviously many other touch points in the ENT journey where we can look to streamline and improve the patient journey using the portal. And I also just wanted to call out that one of the biggest areas of work that we've been focusing on is getting people easy access onto the portal. And I wanted to call out the work that Melissa Gogley has been doing in this space as well. So our take-home points from our journey with virtual care at the Children's is that all our projects have focused on the problem. They've been problem-based with an emphasis on where we can add value, not only to the clinicians, but the consumers. And a recognition that if we're not adding value, we're never going to be able to implement these new ways of working. We've had to implement and then iterate. We don't get this right the first time, and it's really important to be agile and be able to respond to what we're learning on the ground. And that careful evaluation is absolutely critical to ensure that we're actually improving the healthcare system and not just adding more and more equipment and technology into a system that's not improving our efficiency. I now want to turn attention to virtual urgent care. So as I mentioned earlier, we took this to the Royal Children's Hospital ED and suggested this might be an interesting model to pursue, and we were met with resistance. And the reason we were met with resistance was there was really valid concern that we might start to cater for a new cohort of patients rather than do what the intention is, which is divert from ED. Why did we feel we needed to divert from ED? Well, we know that there's problems with hospital overcrowding. We know that if you want to get gastro, a paediatric hospital wait room is the place to go. And this is the volume of patients that we see. The red bar is the lower acuity patients, patients who are triaged 4 and 5. And the thinking behind this is that this is the cohort that we could keep out of hospital and free up the in-hospital resources for the triage 1, 2s, and 3s that really need to be seen with a higher degree of urgency. We also know that the healthcare landscape is really confusing for consumers at the moment. There's a whole lot of services that do exist and can provide help. But as a consumer, how do you know where to go? How do you know that some of these services exist and which is the right one for your child at the right time? We were funded by the Northwest PHN to answer some of these concerns and to design what might be a virtual care solution that really responded to these problems without creating scope creep. We asked, how would we get the right cohort? Who is the right cohort? Who is the most appropriate clinician to see that cohort? What sort of hours do you need the service to run? And most importantly, how are we going to evaluate this and understand whether or not it's an effective model of care? What we learned through our co-design process was that there was a huge appetite for a virtual urgent care service, that the main role would be to streamline care and help the right patient get the right care at the right place, that it was really important that this was seen as a service that would provide urgent medical attention. So not primary care, but you needed urgent medical advice. You were thinking of buckling your child into the car and driving into ED. And we learned from our consumers that they really struggled with that decision, whether they needed to go into ED or not. And the best support they had at the moment was Google, and they felt they needed something more than Google. Our consumers told us that they wanted multiple entry points, that some really wanted an online self-service triage tool that could spit them out some self-management advice and some kids' health info. Other parents really wanted to pick up the phone and speak to someone. And there was a strong appetite from everyone in the room that we should be leveraging existing services, that we shouldn't be adding duplication and inefficiency to the healthcare system, but we should really be integrating closely with services that already existed. The staffing, a diverse workforce, was preferred, and the thought was that many of these patients could be seen by general practitioners or nurse practitioners with paediatric support. And we needed, obviously, to evaluate the service critically. So this was the consensus model, that you would come in through a digital front door. There would be 2 entry points, either self-referrals or through a health professional line. The self-referrals would be able to engage either on an online triage tool or through a nurse, and the healthcare professional line would go straight through to a virtual consult. There would be a diverse workforce, all working in a community of practice, all leveraging each other's skills and expertise. We also collaborated with Nurse on Call and started to investigate what would it look like if Nurse on Call was the entry point. We know that Nurse on Call takes calls from 11,000 Victorian children per month, and that of these, 27% are directed to an ED. We thought that if we could take those 11,000 children, see the 27% that were referred to ED, we could probably help many of those be managed at home or at a more appropriate service, and reduce that percentage referred to hospital to about 10%, or 10% of that 27%, so about 3%. The key differences here is that we're leveraging an existing service in the healthcare system already. The nurse triage would be by phone, whereas the VVED nurse triage is video, so we would need to understand the impact of that. And we're truly targeting a population that have been told to present to ED. So I wanted to share with you where the Victorian Virtual Emergency Department is at the moment. It exists in the system and sees everyone from birth to death. I'm focusing on the paediatric cohort, and it runs 24/7. We have paediatric expertise from 8 a.m. through till midnight, and overnight there are GPs, nurse practitioners, and emergency physicians who have expertise in paediatrics. The current model looks very similar to the model that came out of the co-design process. There's a self-referral arm and a health professional arm. Since it started, we've seen almost 50,000 children, and you can see the growth there. We are growing exponentially. Seen by a variety of healthcare professionals. The majority of patients who present are self-referrals. The majority are managed at home, so 80% of our patients are managed at home or advised to see their GP the following day. A very small percentage get referred on to a primary priority care centre, and about 10 to 12% end up in ED. We've had a strong partnership with Ambulance Victoria. So of the 5,500 children where they've visited in the home and felt that that child does not need transfer into hospital, we've managed to support that decision-making and keep 93% of them at home. So that's 93% of 5,500 children who have not had to be travelled into hospital, experience ambulance ramping, wait to be seen in ED, but they've managed to stay exactly where they are and get the help they need where they need it. We've had a particular success in partnering with Ambulance Victoria in their CROUP guideline. So in partnership with Ambulance Victoria, we've seen an increase in patients receiving steroids in the home, reduction in the number of children that have needed to be transferred into ED for CROUP. And of those patients with CROUP, 31% have had a VVED consult, of which 90% have been managed at home. So it's a really successful outcome. Not only are we supporting patients to stay in the right place, here's a quote from one of the paramedics. I've consulted with Dr. Felicity a few times now. She's always so helpful. She involves us in the assessment, takes time to educate us about the different assessments, findings, what to look for. Participation in her consults has been really beneficial for my own professional development. I've learned so much about assessing paediatric patients and care pathways. So we're providing a really important role in capacity building amongst our community providers as well. We've also partnered with urgent care centres. So previously, when the expertise in an urgent care centre, recognising a number of our urgent care centres are now staffed by nurse only, they certainly don't have access to paediatric expertise. We're now able to take those calls and support the decision whether or not they truly need to travel into an ED. Of the 1,500 children that have contacted us, majority of of children have been able to get the management they need in the urgent care centre rather than travelling in. And you can see as well the growth there over time and the numbers of children that we've seen from urgent care centres. We've been really mindful to create a system that is equitable and considers our First Nations population. Aboriginal and Torres Strait Islanders are overrepresented in our registrations, but we also know that follow-up of the advice they're given is not always 100%. And this led to the institution of a follow-up phone call. And through this process, we were able to detect a child who had a bud and battery ingestion and hadn't gone to ED. We've identified that on the follow-up phone call and was able to get that child the help they needed. So this is a massive body of work that is being led by Jenny Hutton, but has been a real priority for the service. We're also undergoing the same quality measures any physical ED would take to understand whether we're providing safe and effective care. We have much lower wait times than a physical ED. We are much more easily able to surge our staff when times get busy because it's virtual and you can just jump online and see a few patients and help out. As a result, we have a much lower rate of being leaving without being seen, and we've had 0 significant adverse events and no paediatric mortality related to VVED to date. And obviously, the patients are extremely happy. I'll share with you some quotes now. My daughter was seen by a doctor who was absolutely thorough, caring professional. She left no stone unturned. There was really no difference between virtual and face-to-face. Being seen by the VVED doctor was a much better outcome for our family. It allowed us to manage our son in a comfortable place at home with the confidence that he received the treatment that he needed. This is a fabulous service that I used one morning when my son woke up with croup. 10-minute wait, thorough video call with a triage nurse, 10-minute wait, thorough video call with the ED doctor. The script was sent via SMS in a minute, all for free, all while sitting on the couch in my PJs with a sick child. Highly recommend if you can't get into the doctors and don't want to wait for hours in an emergency department. It was our first time and a really positive experience. With 2 small children living regionally out of town, this experience saved us greatly. It saved us the hassle of travelling, organising a babysitter for our other child, waiting at ED for all hours of the night, usually long wait times at our hospital, and the added stress of all of this in the middle of the night. And the final quote, we've used the VVED several times now and feel very fortunate to know about it. It's definitely saved us a few trips to our local ED. Breathing issues are always scary, and I know from past experience that things can change very quickly with kids. Recently, in the middle of the night, when my toddler had a viral-induced wheeze, I was worried about her breathing. I knew she needed medical attention. Being able to get her assessed from her own bed almost immediately and have the doctor and nurse come back and assess her at regular intervals to make sure she was responding to the treatment was amazing. It certainly put my mind at rest, knowing she was okay. So here we are at our current state, and I'll just point out the technology. So we're using a ZDoc registration form provided by my clinician, and it has the registration form available in 22 languages. So a big focus on ensuring our service can be accessible and equitable. We also have interpreters required when through the consults. The patient then gets registered, and we've got a manual transcription process happening to get that patient into our IPM. And then the nurses are using an Odyssey triage tool to support their triage assessment. When they're seen in the virtual consultation, we're now documenting on Cerner that went live a couple of weeks ago. We use Medi records for our scripts and SharePoint for our orders for any tests or imaging that we need. And the team are collaborating and communicating via Teams. What's missing from the co-design process? You'll remember that there was a strong appetite to have an online triage tool, and that's certainly somewhere where we think future investment would really enable our service to scale further. You'll notice we do take calls now from Nurse on Call as part of our healthcare professional line. We have looked at the administrative time, and we know that our clinicians are spending far too much time on administrative tasks, and there is certainly room to improve the technology to enable our clinicians to operate more at the peak of their scope of practice and spend less time in administrative. Other than that, we've pretty much ticked all the boxes from the key learnings, other than that automated online triage tool from the co-design process. The last point was to evaluate the service. And we're at the brink of doing a randomized control trial with Nurse on Call, where 50% of patients who are advised to go to an ED will be referred to VVED, and 50% will go to a physical emergency department or be advised to go to a physical emergency department, because we don't actually know who follows the advice. We will then use linked data to follow up what healthcare each patient receives in the following 7 days to truly understand whether VVED is a ED diversion service or is simply adding additional layer to the healthcare system. So this will be a really important piece of research. What might the future state look like? I still think the healthcare system is incredibly confusing for our consumers. VVED is one of many options. There's been some promotion on advertisements through the TV to say, why don't you go to a PPCC? Why don't you go to VVED? Why don't you reach out to Nurse on Call? Patients still don't know where to go. Can you imagine a future where, as a consumer, you had 2 choices? A life-threatening emergency, call 000 and AV will take you to ED. If AV get there and they don't agree it's life-threatening, they can reach out to VVED and redirect your care. If it's not life-threatening, either engage in an app or call 333, and that will direct you to the most appropriate care. If it looks like you need emergency department, be seen by our virtual ED service first, and they can decide whether you truly need to travel into ED. I think the options to make our healthcare system more efficient, more streamlined, and less confusing for the consumer really lie in streamlining our care options in this way. So what have I learned along this journey, and what am I hoping that you will have learned through me sharing these stories? Technology is important, but it's certainly not the thing we should be focusing on. We need the model of care first. And the VVED is a prime example where we've used clunky legacy systems, but still been able to put forward a really valuable model of care. Co-design is critical, and we need the co-design to inform the model of care. And as we continue on this journey, we need to understand how these virtual care models are contributing to our healthcare system in a meaningful manner. And I will now stop sharing.
Thank you so much, Jo. From the rooms.